Now we're going to start into the psychiatric emergencies. This is that lecture that we didn't get to finish the other day in class. When we're going through the psychiatric emergencies, we're going to start off with, a case study, and then, like I told you yesterday, or I told you during the class, that we're going to talk on suicide and talk on a topic that it's really hard for people to talk about. It's hard for people to admit to, and it's hard for people to actually understand. I will tell you that the content that I'm using for the suicide aspect of it, particularly when it's affiliated to first responders. It's not my own. It's actually from a course I took just last week, where there's a group here in the state of Wisconsin who is starting to develop and create a hope line type of a course for first responders and suicide. It's actually a course that we're looking to bring in separate of our paramedic refresher here at UW. So keep your eyes peeled on our Facebook page and any other type of communications we might have about that upcoming course in the next few months. Let's get into the psychiatric emergencies, though. So we're going to start off. We're going to get dispatched to a residence for an individual who's not acting correctly. It's kind of our standard dispatch information, right? When we get for 911, normally there's not always that good information that we need. So when we get told we're not thinking about somebody who's not acting correctly, hopefully we're thinking of this AEIOU tips. A little mnemonic to remember what's going on. As you can see here, A, alcohol, acidosis, ammonia, arrhythmia. E is endocrine electrolytes and encephalopathy. I is infection. O is oxygen, overdose, opiates. U is uremia. T is trauma, temperature, thiamine, insulin. I is insulin. P is poisoning, psychiatric. S is stroke, seizures, syncope, space, occupying lesions, and shunt malfunctions. So we have that list, that AEIOU tips. Now, how do we assess for it? How do we look for it? How do we determine all that? Well, what you need to do is you can look at the patients, how they're dressed, their grooming, their posture. Are they wringing their hands? Are they have facial grimaces, mannerisms, actions, violence? What about the speech? Is it spontaneous or pressured? Slow or fast? Soft or loud? Understandable or not? Is it gibberish? Is it appropriate or inappropriate? Is it mixed, confused words? Or is it full, inappropriately used sentences? Or is it completely delusional? What about their mood? What's their mood like? Are they depressed, euphoric, manic, anxious, angry, agitated, fearful, guilty? How are they thinking? When you're assessing them, you can ask, what are you thinking about? What are you seeing? What are you hearing? Are they having racing thoughts, hallucinations, maybe auditory hallucination, sensory hallucination, where they're seeing spiders at the wall, somatic, so strange body sensations? Are they obsessive, delusional, suicidal, unconnected, disturbed? What about distorted? All of these things come down to your AEIOU tips. Each of these different signs and symptoms will be associated with these different letters. So back to our patient that we're talking about. So your patient is going to be anxious. They're going to be constantly moving. We're going to be aggressive when you approached, and refuses to let you touch them and tells you their heart is racing. So what'd be some differentials? Maybe anxiety attack. Maybe a psychosis. How about maybe maybe an excited delirium? Maybe, like I said, anxiety. How about panic attack? There's a lot of various options that you could have. In our case today, it's going to be the excited delirium. So the characteristics of excited delirium. They're going to act bizarre. They're going to be aggressive, agitated, ranting. Hyperactivity, paranoia, panic. At least that could be their physical actions that they're going to have. How is their body going to present to you medically speaking? Well, they could be hypertensive, tachycardic, diaphoretic, dilated pupils, tachypnic, abnormal tolerance to pain, hypothermia, noncompliance, and endless endurance and strength, which could all that could eventually lead to a respiratory and cardiac arrest. How do we treat these patients? Number one thing, keep the situation calm. You keep calm and you try to keep the patient as calm as possible and not agitate them further. Then, what do? Well, we might have to restrain them. We might have to use law enforcement. We might have to use fire. We might have to take this patient down and restrain them from preventing any further harm to themselves, bystanders, or yourself. Brandon did a nice topic in the first day of class talking about physical restraints and chemical restraints. But when you're thinking about restraining a patient, especially physically, think of any joints. Think of the range of motion. Think of the muscle groups that are associated. Think of where your center of balance is. For an example, with a male patient, you could put your hand on their chest when they're laying down, and you could use an extremely little amount of force, and they cannot get back up. They could swing at you with their arms, so you have to secure the extremities. But you could have one hand and a very light amount of pressure right around that chest area, and they cannot stand back up. If you have a significant other or a friend or a colleague or a coworker that you want to have test this out with, or if you're on an EMS service and you have that new rookie who you want to teach you a quick lesson to, if it's a male patient, have them sit on a non-rolling chair, so one with the four legs. Have the chair go up against the wall. Tell them to sit down. With one finger, you go over, put it on their forehead, right between their eyes, and apply pressure with one finger. And then what you'll be able to do is tell them, without using this chair and without using your hands, stand straight up. If you're doing this correctly and the positioning correctly, a male patient will not be able to stand up with one finger on their forehead, because our center of balance is in a completely different spot. Whereas if this was a woman, because her center of balance is closer to her hips, whereas a man's closer to his chest, she will be able to stand up no problem if you do this. One time I had students, when I was teaching an EMT basic class, actually had the students do this. I had a 6'5" person and I had a 5'2" woman. I had a 6'5" person sit down, and the 5'2" little tiny, she was this little petite thing, come over and with one finger was able to stop the 6'2" individual who was going into the military, so he was trying to get in shape. She was able to hold him down with two fingers. It's all by understanding your center balance. So when it comes to your physical restraints, you got to think about that kind of stuff as well, because you could add, if you understand the anatomy, add an extra precaution without having to use that excessive force. When we get to chemical restraints, you got to ask the question, is this patient in clear and present danger to you or your crew or themselves? Well, we already decided they are. If we're going to use physical restraints, we need to use chemical restraints. We don't need to have them hurt themselves because they're pulling against our restraints. Some medication options you could give. These are kind of from at least the dosages, are going to be from the Dane County protocol. Your department might use something different. You can use ketamine, 2 to 4 milligrams per kilogram. That's going to be an IM injection. Benzodiazepine, midazolam, lorazepam, and that could be 1 milligram IM injection. You can give your antipsychotics like Geodon, which I believe, if I remember right, is 10 to 20 milligrams IM. And you could give haloperidol, which is 10 milligrams IM, or you could give risperidone, which is another antipsychotic that might help you out as well. I would personally, as much as I love ketamine, in a patient who is in an excited delirium, I'd be very careful with that, because of the fact that when they come out of it, they may start having more hallucinations, which could be very deadly for you and them. Another treatment that isn't in a lot of protocols when it comes to administering to excited delirium patient might be sodium bicarb. Because they've been breathing so fast and moving so fast, they might have a depletion of their bicarbonate in their system, so that once they slow down, they go super acidotic from respiratory acidosis and they collapse and go into cardiac arrest. Like I said, most protocols don't have it, but it'd be something you could always pass by medical control online and see if they'd be willing to approve that treatment plan. The other psychiatric issue that the National Registry wants us to talk about this year is suicide. Unfortunately, with COVID, this is becoming an increasingly difficult risk. More and more people are talking about it, thinking about it, and actually acting on their thoughts. So we're going to get more calls for suicidal attempts this year, I have a feeling, than we have in the past. Textbook answer of what suicide looks like. So you have a history of depression or mental disorders, previous suicidal gestures or attempts, history of family or child abuse, feelings of hopelessness, unwillingness to seek medical health care due to a stigma, might be the EMS and fire and police mentality, feeling of being isolated from others, history of impulsive or aggressive behavior, inability to access mental health, recent diagnosis of a serious illness, especially an illness that results in a loss of independence, recent loss of a loved one, job, money, social loss, access to firearms, PTSD, alcohol or drug abuse, loss of a relationship, gives away personal belongings, cherished possessions, physical or mental stress, major physical stress such as surgery, long periods of sleep deprivation, inability of the mechanisms to carry out suicide. That seems like a very cut and dry list, doesn't it? It's one that we'd probably want to think about and look at. And, when we take care of our patients, it's easy to talk about this stuff to them. We go to a house, we see a patient we've never seen before, we talk to them. Are you trying to hurt yourself? Yes. Do you have thoughts of suicide? Yes. What is your plan? This. Okay. We miss the stigma. We miss the thoughts. We miss the mentation of maybe trying to take the next step and help them. Why? Why is it that suicide seems to be your only option? Because suicide and the ideation of suicide isn't just a one-time fleeting thing and just somebody acts on it. Suicide is an idea that turns into a cycle, that every problem, everything spins and spins and spins around. And these individuals, when they have this idea where they're getting ready to attempt or they are going to die by suicide, they see no other alternative. It becomes the only option that they have to protect themselves. They think it's going to solve every problem that they have. The divorce that they just got, they believe that it becomes the only answer to solve that problem. It's going to make that, X pay for what they did to you. They think that they aren't good enough for family. They don't always have to have a history of depression. It can be an acute problem that leads on. Look at Robin Williams, for example. That man was an individual who made the world laugh. Yet he had the biggest depression on the side that most people don't know about or didn't know about. Look at, he had a quote one time that, those who try and make the world laugh are the ones who are probably hurting the most because they know the pain that the people are going through and they don't want the world to be in pain. So think about that. But then, if this isn't taking care of our patient, what if this is, we get called and it's one of our coworkers, our fellow first responders, a police officer, firefighter, EMT, paramedic, volunteer? What if it's one of them? You have to go into a residence where you've seen a fellow coworker who you've been on a fire call with their brain splattered across the wall. What about that? How's that going to affect you? How is that going to affect your team? And, coming through our courses, we trying to get you to be the best we can have you and give you education like you wouldn't believe. So we're going to hold you to the standard that maybe you're going to be you're a leader of some sort in your group or want to be. So how can you help? How can you be the next step? Well, let's first start about this. Suicide is a public health crisis here in the United States. There is an estimated 40,000 Americans who succumb to dying of suicide annually, and 3.9% of Americans experience suicidal ideation every single day. That's a lot of people. I almost question if that might be more than even the coronavirus numbers over the last year. If we multiply 40,000 by 365, we're going to be getting up there pretty good. So there's a survey that was done by a government group. They asked 1,027 current and retired U.S. firefighters the prevalence estimations of suicidal ideation, plans, and finally the attempts. 46.8% of firefighters had suicidal ideation. 19.2% had plans, and 15.5% of that 1,027 actually committed, or I should say attempted. Kind of sobering numbers if you think about it. Our profession is one that is not easy to see. It's not easy to do. And the mentality and the stigma that we shouldn't talk about mental health of each other and help each other and help the rookies is something that we need to look at changing in time. So one of the things, we'll call them red flags, but they're also known as taillights. These are a few of the slides from this group. These are what you can look out for. But I wish I could say that if this person had this, they're going to have suicidal ideation. It doesn't work that way. There is no clear-cut way of saying that if X happens, Y is going to happen. But as a team, your family, your friends, if you're the leader of your group, watch for your staff members. Are they having frequent angry outbursts? Are they suddenly increasing their use of alcohol and other substances? Are they neglecting their responsibilities? Are they reckless and dangerous behaviors that are abnormal for them? Do they have serious financial difficulties? Do they stop paying their bills? Are they withdrawn from their family and friends? Do they have critical errors at work? Do they talk about not wanting to be alive or have a sense of hopelessness now? Or are they having worsening appearances or hygiene? Each of these are very vital. What, as leaders, as team members, what can we do for this? Well, if we have a coworker who suddenly is having more frequent outbursts, and you're going, that's not who John is or Jane is, go up to him. Hey, instead of fighting him and picking a fight, go up to him and go, hey, I've been noticing you're, more angry lately. Are you okay? Is everything okay? Is there something we need to talk? Or do you want to talk about? Because being willing to be there, listening to your friends, coworkers, may be one of the biggest things that will help prevent this more in our profession. Being able to open up that door to let them walk through to come and talk to you, showing that you care. But then, the suicidal ideation and actual attempts, isn't just a one event and done situation. There's this interpersonal theory that was done by Dr. Thomas Joyner. We'll talk about this a little bit more in the next slide too. But it's composed of 5 major things that have to coincide simultaneously in order for a person to act on their suicidal ideation. They have to have this feeling of isolation and aloneness. They do pull away from everybody because they feel like they're a burden. So you have an individual who, like I said, let's use a divorce for example. You feel like you're a burden to your family, to your friends, because you're not a loner, you're not having that significant other with you anymore. You lost, your meaning. You feel like you're alone. You gain the desire for suicide. You think that maybe this is my only way out. And you have the capability for suicide, meaning that you have the tools, you have the equipment needed, you have the gun, the knife, the pills, whatever. That puts you into a perfect little trifecta. Then you have one last step. It's either the lethal or near lethal attempt. And that's where you get this, this whole situation from. As I said, this is a downward spiral on these people. As you can see, if you're alone, you feel like a burden, you just keep cycling and cycling and cycling around that desire for suicide ideation. Dr. Joyner's theory further goes. So this proposes that a person will not die by suicide unless he or she has both the desire to die by suicide and the ability to do so. What is the desire for suicide, and what are its constituent parts? What is it? Is the ability to die by suicide, and in whom and how does it develop? So it develops as perceived because of perceived burdensomeness, low belonging, social alienation, acquired ability to enact lethal self-harm and injury, and that angel on your shoulder is gone. That one telling you it's okay. The one telling you that you're going to be okay. It's gone. And you don't know why. And that's where, as co-workers, as EMS professionals, we know what our profession looks like. We know the pain it causes. We know the suicidal attempts, the stupid stuff we see people do. We know all that stuff. We've seen it. We process it differently. In the olden days, we were always told, suck it up. It's okay. It's part of the job. We need to change that culture. We need those of you who are, watching this lecture and being part of our class to be willing to talk about it. And this even goes to how you talk to your patients. It works for your coworkers. It works for your patients. But the harder conversation is going to be talking to your coworker. So now that we have you down and depressed a little bit about this topic, let's talk about how to fix it. Let's talk about how to better ourselves. So we need you to chart. If it's you, your coworker, you got to have them chart their own course. So they need to gain a sense of purpose and feeling of control again in their life. That's part of why that downward circle. How do you get them to have one footing to start stepping in the right direction? Help prioritize what is important. Find opportunities to live, values, sense of accomplishment. Boost your confidence. Maybe you can give them something, meaningless to you, but something that will give them a success to make them feel better and boost their confidence. Some common roadblocks that they're going to run into. They're going to have a lack of motivation or boredom. They're going to have a mismatch with values, unproductive patterns in thinking. But the key is if you have friends, coworkers, whatever, that are going through this, don't let them start over. When they start making progress, hit a roadblock, and they feel like they need to start all the way back over to step one, don't let them. Help them recalculate, or tell them, recalculate your route. And go another path, go a different way, and get to where you want it to go. But don't start over completely. How to accomplish your goal. Create a plan to overcome potential obstacles. Find ways to trip over your goals. When I mean trip, it's kind of like air quotes type of a trip. And that you can stumble into these opportunities and goals that you're aiming for. Personally commit to the goals. Share with others. Talk about your story. Talk about your ideas, your plans, your ambitions, so that others can help hold you accountable to them. Revisit to track progress. And even maybe start a journal that kind of keep yourself on track to see, so you can go back and say, hey, I was here, but now I'm here. And you can see that trending and going in your course forward. And then the last thing I'm going to leave you with is a little video. So one of the things is gratitude is so important. If you're down, one of your coworkers are down, friends are down, maybe recommend this to them. A positive emotion is super strong. But unfortunately, it takes 7 positive things in order to replace one single negative thing. So I'm going to have you watch these individuals and see the responses to doing this gratitude.
Shut up.
What? Wait.
Oh, he's going to be so embarrassed.
What makes you happy? Having fun? Hanging out with friends? delicious food, making money? Well, consider this. Psychologists have scientifically proven that one of the greatest contributing factors to overall happiness in your life is how much gratitude you show. Yeah? Think about that. Go ahead and marinate on it for a second. You can thank me later if you want. It'll make you feel better according to this study. You go ahead and click on it and read it if you want. Or you can keep watching because we read it and we thought it might be fun to test out for ourselves. We gathered a selection of volunteers to act as our subjects. First, we gave them a test. They didn't know what we were looking for, but it gave us a pretty good idea of their current level of happiness. We asked them to close their eyes and think of somebody who was really influential in their life, somebody who did something really amazing or important for them. We had them write down as much as they could about why this person was so important. Now, a lot of them thought at this point the experiment was over, until we really put them on the spot and tried to get them to call that person and read what they wrote about them. Thank you, Jessica. We're going to have you call your mother. So who is that right person for you?
Person is my sister, Erica.
We're going to give Erica a call.
Okay.
Who'd you end up picking?
Friend of mine, Craig Ains.
Her name is Dora.
My college accounting instructor.
Really? Is this somebody you're still in touch with today?
No, I'm assuming that he's passed on.
That's a
To the
shame.
great beyond.
You up for it?
Yes.
What would you say if we called up Dora?
Oh, well, we can try, but she lives in Britain.
In Britain?
Oh, no, never by heart. This is awful.
That's fine. I don't know my mom's number by heart.
If it's true that those who are going on are looking down on us, maybe he realized it is scratch.
Hey, sweetheart.
Hey, how you doing?
Yeah.
You got a second? Where you at, in the hotel?
I am. I'm in the hotel. You scared me when you asked if I had a second
No.
or something's wrong.
No, I'm on like this little TV show, and they told me to talk about the person that influenced me the most, and I picked you, and they're making me call. They're making me call you.
Oh, wonderful.
Hi, you've reached Craig. I'm not here right now.
At the tone, please record your message.
Oh, come on.
Hello?
Hi,
Hi.
Erica. It's me.
All right, so I got to read you this paragraph. Can you hear me?
Yes, I can. Go ahead,
All right.
sweetheart.
All right. The person that influenced me the most would be my mother, Marlo Dawson. She is a single mother of 2. She is a very hard worker and dedicated to her family.
Hey, Craig. This is Loie. This is going to be a funny little voicemail, so I hope you enjoy it.
I'm so sorry for calling you at 4 o'clock in the morning.
I have to read this to you, okay? And you can't say anything or, I don't know. You can respond, but I probably will just keep going. Okay?
Is everything okay?
Yes, but I have to read this out loud to you.
The person who has had the biggest impact on my life outside of Jesus Christ, who is responsible for my existence, was my college accounting instructor. He had a joy and enthusiasm for his job like no other teacher I have ever known.
I love her to death, and she keeps me going with positive talk. She is a woman that knows what she wants and won't give up until it is achieved.
Oh, something. I don't know what. I'm about to cry because that's so beautiful. I have to say that's just wonderful.
I first met Craig on an independent feature film set in Whitefish, Montana. I recently have been sending Craig a lot of positive thoughts as he suffered a series of health problems. Despite his medical problems, he's continued to work and take pleasure in the small things in life, like sitting quietly with his wife Janine on the porch.
Erica is my older sister and my best friend. Sometimes it even feels like we are twins. She's my #1 fan and my #1 supporter. She makes me happy because despite all my mistakes and my decisions, she still loves me no matter what.
Your friendship is everything. And you are one of the most important person in my life.
Even when she has a kid and many children, I will love her more than her kids. Okay, maybe not. I will never forget when she flew 3,000 miles at the drop of a phone call to save me from a breakup.
And being blessed by having a son like you. I love you.
Bye.
Why did you do that to me?
I don't know because they made me do it.
Thank you for picking up. Bye, sweetie.
And then they're like, here, you're gonna write this letter. And then I wrote like this whole long ass letter, which, you know, I like don't write. And then all of a sudden they're like, hey, guess what? Now we're gonna call her and you're gonna read her this letter. And I was like, what the
Before we let them go, we gave our subjects one more happiness test. Now, we mixed up and rephrased the questions so they didn't know they were taking the same test twice. For those who took the time to actually write something down but couldn't make the phone call for whatever reason, we saw happiness increase between 2 and 4%. Good, but not exactly mind-blowing. Now, for those who actually picked up the phone and personally expressed their gratitude, we saw increases between 4 and 19%. So either way, expressing your gratitude will make you a happier person. But you want to know something really interesting? The person who experienced the biggest jump in happiness was the least happy person who walked in the door. What does that mean? That means if you're having a particularly tough time, trying this out will more likely have a greater impact on you. Trust me. I'm in a lab coat. In fact, while you're at it, film it and upload it to us, and we'll do something awesome with it. I'm Julian, and this has been The Science of Happiness.
So that's the video, you know, talking about gratitude, being grateful, all that. It's super important. You saw how much it improved. One of the tips for resiliency of helping first responders is actually starting a gratitude journal. Daily, write down 2 to 3 things that you're grateful for and watch how much it improves your mood. And watch how much it improves your mood. It's so powerful to be grateful, think about that kind of stuff. You know, maybe if you have a coworker who's down, show them this video, suggest that to them. Like I said, this is information I took from a class I took about a week ago. This will be a topic you're going to see us talk about more and more, especially with COVID going on. How many more people are committing, who are dying by suicide, who are having suicidal ideation, the burnout that we're facing in our profession, the stigma that we have. This is something that we're going to be broaching more and more as time goes on. And the last thing is, you know, with this whole topic, especially when it comes to our first responder, or all these major negative events that we're talking about here, the loss of a job, loss of a loved one, the whole thing is that's kind of your identity. If you think about it, when we meet a new person and they ask you what you do, our first thing we do is we talk about our job. We talk about being a first responder. We talk about our profession, helping people, all that kind of stuff. When you lose something like that, you kind of lose your identity, and that's what can lead you down this path. So remember, always try to think about grateful things. Always try to help the new ones and show them that it's okay to talk about stuff like this. And hopefully we can turn this trend around in time. We just lost another one here in Wisconsin who died of suicide last week down by Milwaukee area. So hopefully in time this all will switch around a little bit and we can help each other out. All right. Sorry for having such a massively depressing lecture on suicidal ideation and psychiatric emergencies. I promise in a couple of years when you come back, this won't be as depressing of a topic, hopefully. So enjoy, and let's get the rest of the online work done.